Hey everyone. So today we'll talk about coronary artery disease and acute coronary syndrome. Before we start, let's just have like brief idea about the heart. So our heart is a fist-sized organ that pumps blood to the whole body. On an average, it beats 72 times per minute, which in a lifetime is about 2.5 to 3 billion times. So in order to do that, it needs to have continuous supply of energy, which is given in the form of aerobic respiration, for which we need to have the oxygen. And we supply oxygen to the heart with the help of the blood. And the artery that supply blood to the heart, we call it coronary artery. So the coronary artery is the artery that supply blood to the heart. We have several arteries that supply blood to the heart, such as right coronary artery, left circumference artery, left anterior descending artery, and so on. For this class purpose, I want you to just know at least one of the artery, which is your left anterior descending artery, or in short form, you will see LAD. LAD is one of the coronary artery that supply blood to the majority of the left side of the heart, and left side of the heart is what pumps the blood to the whole body via aorta. Now, when we talk about the coronary artery disease, we have chronic versus acute. Chronic means it's been going on for a long period of the time. It's there, but that's something which is in control. Acute is sudden and it is severe, which is further divided into two categories. We have unstable and Nstemi, which we call it non-ST segment elevation. And on the other side, we have Stemi, ST segment elevated myocardial infarction. We'll talk more in detail about what they are and how they function and behave and everything in detail. But before that, let's just talk about something. So the coronary artery is the artery that supplies blood to the heart. But because of the several factors, we can have problem in that coronary artery, and we can see there is an occlusion in that coronary artery. So let's say that this is my artery that supplies blood to the heart. For some reason, there could be a plaque buildup. If there's a plaque buildup, then originally the blood is going properly over this one, and now due to the plaque buildup, there is still blood passing, but the amount is reduced. Or there could be a situation where there could be complete occlusion, and those things can cause us to have severe adverse action on the heart itself. And the most common cause for those plaque buildup, which we see over here, is called atherosclerosis, which in simple term means the hardening of the artery. So the artery that supplies blood to the heart gets hardened, and as a result, now we have the plaque buildup. And reduced amount of the blood flow through those arteries can cause us to have consequences on the heart. There are several factors. We have risk factors which are modifiable, and some of the risk factors that are not modifiable. So let's just talk briefly about what they are. So when we say the non-modifiable risk factor, it includes the family. If there is someone with a coronary artery disease in the family, then there is a higher chance, 2 to 7 times more likely that the patient will have it. Age, from age 65 to 74, there's a higher chance the patient will have it. After 74, we have seen that number gets reduced. Gender-wise, male are at the more risk. Male have more than compared to female, but female does more than male because their symptoms are more vague than male. As well as for female, up until the age of 60, we have estrogen that is cardioprotective in nature, but after that, with the menopause, there is no more estrogen production, which put them at the high risk. Women, especially with the type 2 diabetes or obesity, is at the higher risk as compared to the men or women without type 2 or obesity. Ethnic wise, really high in black population, African American initially, but then over the period of the time, especially after the age of 65, Hispanic people takes over. So they are at the higher risk, Spanish and African American. For the CAD, hyperlipidemia, too much of the cholesterol is one of the major factors, especially in the United States with the food and the cholesterol. We can have a lot of the CADs. Cholesterols are of several types. For this class purpose, let's talk about the two ones. We have HDL versus HDL. Sorry, LDL versus HDL. H for helper, which is your high density lipoprotein. They are good cholesterol. You want to have it more than 40. LDL, lethal, low density lipoprotein. They are not good for you. You want to have it less than 100 in your blood. You also have triglyceride, phospholipid triglycerides are the bad kind of cholesterol you have in the body. hypertension. Anything with the blood pressure of more than 140/90 over the period of the time can cause us to have strain on the blood vessel, which put us at the higher risk of having the blood plaque buildup, or those blood yes, those lining on the lining of the artery. We can have the plaque buildup. Smoking puts us at the higher risk, 2 to 3 times more likely, because smoking, what it does, it causes us to have those platelets to be more adhesive in nature. So they bind, they clump together, and can cause us to have plaque buildup. Then we have the diabetes mellitus. We already talked about this. Diabetes mellitus, patient with the diabetes mellitus are at the higher risk, especially type 2. It increases the LDL, your bad cholesterol, and triglyceride, another bad cholesterol, and as well as it will decrease your HDL. Your good cholesterol will be decreased and your bad cholesterol will be up. With the patient with the diabetes mellitus, obesity again is a major causes for the coronary artery disease as well. Sedentary lifestyle. So if a patient has a sedentary lifestyle, or anyone with a sedentary lifestyle, then they're at the higher risk for CAD. What do we consider for the sedentary lifestyle? If anyone who is not doing at least 3 times a week for at least 30 minutes of a walk or any kind of exercise, and that's a sedentary life. Stress and anger can cause us to have cardio. Sorry, stress and anger can cause us to have the coronary artery disease as well. Alcohol intake, 1 to 2 standard drinks can cause us to have increase in HDL, low blood pressure, healthy genetics endowment. Wine is a vasodilator. So when we talk about the alcohol, they're not good for you. But when we talk about the wine, especially the red wines, they seem to be more cardioprotective in nature. But alcohol consumption in the severe amount is again can cause us to have the coronary artery disease. Oral contraceptive can put us at the risk for having the blood clot, which can get dislodged and go through the artery, coronary artery, and from there it can cause us to have the complete occlusion, which can cause us to have the risk for having the heart attack or another of the coronary artery disease. So those were some of the risk factors which we had that put us the patient at the higher risk for coronary artery disease. So now, atherosclerosis. What's the etiology and pathophysiology behind those plaque formation in the coronary artery? Well, there's several causes for that: diabetes, hyperlipidemia, cigarette smoking, obesity, and those kind of things. But know a couple of things before we go in detail. Atherosclerosis is an inflammatory process, so it causes us to have inflammation. Whenever there is an inflammation in the body, our white blood cell thinks that there is an attack, and they send their troops. The first one to arrive is the neutrophil, if you remember from your previous classes. Now let's talk about this. Let's say that we have a vessel. This is your coronary artery, totally fine, everything is good, blood is flowing through this. Over the period of the time, the patient develops us to have the chronic hypertension. Now those blood flow is getting really high. The pressure of the blood is really high. And if it is chronic, then over the period of the time, those chronic blood flow can cause us to have tears and insult to those vessels. Whenever there is an insult to those vessels, then the inflammatory response gets activated. With that, we always have the possibility that there is a lot of bad cholesterol floating in the blood. There is a lot of lipids such as LDL, triglyceride. This starts to clump it over here. So the small insult has now become this plaque over here. With this, your inflammatory response is activated. So the neutrophils is like, something is wrong, I need to fix it. It will come and start to make the foamy cell over here, which further raises the plaque buildup level over here. So the small insult due to the chronic hypertension has now become a big plaque. What it will do is the amount of the blood flow is still there, but the amount has reduced significantly, which can cause us to have ischemia and also the tissue death, which can cause us to have the myocardial infarction. So one more time, whenever we have a vessels totally fine over the period of the time due to the several factors, so in this case, let's say the chronic hypertension, it can cause us to have initial stress to this coronary artery. With that, it activates the inflammatory response. Simultaneously, there is a lot of LDL, the bad cholesterol, your triglyceride, and those kind of things starts to building up over here. Since it's activated the inflammatory response, your neutrophils also comes and try to take the care of the problem, which starts to form these small foamy cells, which now has caused us to have the new lining, new plaque buildup lining. In itself, it has reduced it, the amount of the blood flow. And this is what we call it unstable angina, or with Nstemi. This is what we see. where we have the reduced blood flow. But it gets worse. Once this stable plaque, let's say for some reason, got ruptured, then it starts to bleed. Then our body thinks it is bleeding, so the platelets come and try to help us. When the platelets come and help it, it will start causing us to have more plaque buildup. You see what happened here now? All of a sudden, the blood flow has been completely compromised. Let's say that something like this happened in your LAD, which provide blood flow to the majority of your left part of the heart. With no blood flow, the coronary artery will not be able to generate any energy, and the patient will have heart attacks such as STEMI. So that's the difference with the STEMI and versus non-STEMI or unstable angina. We'll go in more detail and we'll have more idea, but that's the basic pathophysiology of that. So stage 1, there is a tear in the artery, then we have the plaque buildup, and eventually once that plaque, once stable plaque, once gets ruptured, platelets comes and try to fix it, but then causes to have the more problem by blocking the complete artery that supply the blood to the corner, to the heart itself. And that was the pathophysiology. Now we need to do the evaluation to see how we can manage that. There are several things we can do. We have C reactive protein. The only thing is C reactive protein, ESR, those things can tell us about the inflammation. It will not tell you where there is inflammation, but it will tell you that there is an inflammation in the body. Remember, since atherosclerosis is an inflammatory disease, we will see the CRP level to be increased. Then we can get an idea that there is an inflammation. But the one specific test which we do is your plaque test, and I will remember that. Plaque test will just get an idea about the plaque buildup in the artery, and they are considered highly accurate as compared to the other one. We can also do the arteriogram, where we can just inject the dye in the artery and see how that dye is flowing through. And if there is a blockage, then the dye will not be able to cross that barrier. We can also do the calcium scan as well to check for that. There is one specific test as well, MBCK, that can give us an idea, which is specific for the heart muscles, that can give us an idea as well. But mostly when we do for the lab, we go for troponin as compared to the other ones. So those are the different kind of tests which we can do. And that's some of the basic things we need to know about the coronary artery disease. Okay, now we can move to our favorite one, which is coronary syndrome. Now let's talk about some of the things with the coronary syndrome. Whenever we have any kind of occlusion, which we all saw earlier, let's say that this was our coronary artery and we saw the occlusion over here, we can literally see from this one that the amount of the blood flow is reduced. With the reduction, what we can conclude that the blood amount has been reduced and not all the blood is going through. As a result, the heart will not get enough blood and it will start having the pain, and we call it angina or angina pectoris, which just means like the chest pain. That's just the fancy word of saying the patient is having a chest pain, angina pectoris. So the primary reason for that is atherosclerosis, which is a plaque buildup in the coronary artery, or it could be due to the vasospasm, where all of a sudden your artery collapses and spasms, or it could be the thrombosis as a contributing factor, where we can have the clot in the lower extremities, which can travel all the way to the coronary artery and can cause us to have the blockage. If there's a blockage, reduced blood flow causes us to have pain. For myocardial infarction to occur, we need to have at least 75% or more of the stenosis, which just means like at least 75% of the artery has to be occluded in order for us to have the heart attack. What's the treatment? One of the options is to use the vasodilator, where this is the vessel. We can dilate and increase the size, vasodilator, until it reaches 90%. If it is 90% occluded, then it will not be effective afterwards. Other thing we need to be mindful about is something called collateral circulation. So our heart is the only organ that starts to beat from 2 to 3 weeks in our mother's womb all the way till we die. So for some reason, let's say that there is an occlusion in this section of the heart in the coronary artery, and the heart needs to have the continuous blood flow. So what it will do is they will start making the collateral circulation, which basically means it will bypass and make the new vessels around the occluded section. What this will do is this will prevent us to have the lack of blood flow. So instead of going through this way, now there is a new pathway. Couple of things. Is this gonna be strong? Not really, but it's still better than having nothing. There is still some blood flow, not the same amount, but there is some blood flow. Is weak, so there is a chance of rupture, but it's still better than having the nothing. That's the collateral circulation, which is just the formation of the new vessels around the occluded section to supply the blood flow. is the collateral circulation. So, and that's right over here. What is collateral circulation? It's the ability of the vessels to make the new vessels around the occluded section of the heart. Now, it could be normal, it could be established, or it could be the total bypass with the total occlusion. We already talked about this. We said angina pectoris is the chest pain, which is due to the plaque in the coronary artery. We have the pain, and one of the things which you can do to reduce that pain is to have the limited movement. Why? Because if you are walking around doing exercise, that needs a lot of energy. It means heart has to get a lot of blood flow to itself in order to pump in. But if you're stationary, if you're not moving around, that the heart can do the same function without using a lot of energy. Okay, so stationary, reduce the pain. Now, when we talk about the symptoms, men have more definitive symptoms as compared to the women. That's why women die more, even the men are at the higher risk as compared to the woman. So for men, you can have the chest pain radiating towards the neck, jaw, down to the left arm. That's where your heart is on the left side. In the woman, it could be anything such as nausea, vomiting. Next thing you know, the patient is having the heart attack. Those kind of things. So just be mindful about some of the signs and symptoms for men. Chest pain radiating to the neck and jaw, to the left side, woman, nausea, vomiting, diaphoresis, tachycardia, dyspnea, and those kind of things. Now we have ischemia. So one more time, ischemia is the reduced blood flow. Again, why we have the reduced blood flow? We talked about this. We said we have a vessels that's occluded, because of which the amount of the blood flow has been reduced. They are of different types. It includes stable angina pectoris, meaning stable chest pain, Prinzmetal angina, that's the variant angina, other name, or silent ischemia, where we have the reduced blood flow all of a sudden with no cause. Or maybe there is a cause, but it is silent. So when we say stable angina pectoris or stable chest pain, like the name says, we have a pain that can be stable with the rest. So it could be brought on by the exercise, but take a rest, the pain will go away. Usually it will last from 3 to 5 minutes, and after rest it will go away. When we need to evaluate that, then what we do is we do the treadmill exercise test, or we can also do some of the we can also do it by injecting some kind of medicine which would put the heart at stress. The reason why we do that is stable angina, pain will go away with rest, so you'll not feel any pain, but that does not mean that you don't have a problem. So what we do is we'll put the heart under stress and see how EKG changes and how the heart reacts with that stress, and that's when we find out if there is anything going on with the heart, to find out with the stable angina. Treatment wise, we need to change the lifestyle. So we need to change the food options such as low sodium diet. If we are having chest pain, then we need to slow it down. Do not try to overexert yourself. Drug therapy includes the nitroglycerin. That's something which we can take sublingually, causes the vasodilation. Or if it is 90% occluded, it'll be a good idea to just have a stent placement, which is a really super easy procedure. Nothing happens where we just have this. Let's say this is the blood vessels. They will take the patient, and the patients with the groin side, they'll go through either left or the right groin side, or even with the right or the left radial side, where they'll just go through the radial side all the way to the heart, into the coronary artery, and wherever there is an occlusion over here, they will inject this line and then inflate it. Now with inflated, take out this thing, retract your back, and now this section have a stent place, and this is open. That's your stent placement. Super easy procedure. Patient can go home within 1 day if everything looks good with no bleeding. Then you have the other kind of chest pain, which is your Prinzmetal angina or variant angina. To be completely honest, I feel like this is one of the most deadliest one, just because you don't know when you'll have that. So what Prinzmetal angina is in this one, let's say that this is your blood vessel. What happens all of a sudden, for some reason, if this is your blood vessel, it spasms. With the spasms, now there is a completely occlusion. If this is the vessels, this becomes your vessels. So if there is completely occluded, that there is nothing flowing from this region to the other side. Now if there is no blood flow, then you will have every symptoms like a Stemi. What is Stemi again? When we said Stemi is when you have the total occlusion, no blood flow. With no blood flow, there is no oxygen supply, cardiac muscle cell starts to die, and with that you'll see the T wave elevation, like a really big T wave. So what's Prinzmetal angina in a nutshell? It's the narrowing due to the spasm. What's the cause? It could be due to anything. It could be due to cold, stress, it could be due to the tobacco or cocaine use, and it's kind of like really vague. It is kind of unexplained, and it could happen at rest. Matter of fact, it happens at rest a lot during your REM sleep cycle. So all of a sudden you go to bed, you sleep, and you never wake up. So when a spasm occurs in the normal part, this is your P wave, this is your QRF, and this is your T wave. But what happens with the perimetal angina? This is your P wave, really nice, Q wave, and then T wave, tombstone T wave. Your T wave gets elevated. Other things that can cause us to have T wave elevation is your high potassium, but in this case, it is because of the complete occlusion. So that's what principal angina. Things I'll know is the narrowing due to the spasm. It can be happens due to anything, happens due to the REM cycle of the sleep, and it will have tombstone T wave, so really high elevated T wave. Now, evaluation wise, you can do the history and physical, see if there is someone in the family that had it before, or we can do the ECG, EKG during stressful situations such as treadmill test, nuclear imaging, or coronary angiogram. But the thing is, once that spasm goes away, you will have the normal EKG, everything will look fine, but spasm, if it will stay for a long period of the time, then you can have the problem. So let's say that the patient is sleeping with the principal angina, there's a spasm, they have no idea, especially in the woman, they do not have the pain like other like in male, and as a result they will not feel anything and they'll just die. But for some reason, let's say that the patient is aware that they're having pain, they know they have the diagnosis of principal angina. What they can do is, if there is a spasm of this vessels, as a result it is completely collapsed, we can give them the nitroglycerin, which will cause us to have opening of the vessels. Since it's a vasodilator, we can also use the calcium channel blockers. Calcium causes contractility. You'll block that channel, then it will cause us to have increase in the vessels, which can help during the principal angina. Now, the other one is your silent ischemia. In most cases, we have the temporary shortage of the blood to the heart, and which can cause us to have the chest pain. But in some cases, there is still no chest pain, and that's why we call it silent ischemia, like the name says, silent ischemia. 80% of the time, patients are not even symptomatic. They're walking, they're just playing game sports on the field. All of a sudden, you see they have a heart attack and they die. Major risk factor include if they have a previous heart attack, or they have the coronary artery disease, hypertension, diabetes. That's the main one. The diabetes, smoking, obesity, alcohol, and drug abuse are the other things that can cause us to have the silent ischemia. So I will just know all three of them. Stable is with the exercise relieved by rest, last for 3 to 5 minutes. We do the treadmill exercise test to check for that. Drug therapy includes the nitroglycerin. Prince metal is narrowing due to the spasm, unexplained, happens at rest during the REM sleep cycle. You will see the T wave elevation or tomb T wave. Silent ischemia, mostly associated with the diabetes. 80% of the time they will have no sign and symptoms. They will be asymptomatic. And that were everything about some of the basic idea about the coronary syndrome. Now we'll go in detail. So with the acute coronary syndrome, what we're saying is we're having the sign and symptoms. That's what syndrome is. Syndrome is sign and symptoms of the coronary artery, which is acute, which means it's happening all of a sudden, all of a rapid, suddenly. What it happens is there's a decreased blood flow to the coronary artery that supply blood to the heart, and now because there is a decreased blood flow, coronary arteries are not pumping enough blood to the heart. As a result, heart is not working effectively. And they are categorized into different categories, but to make it easy for myself, I like to keep unstable and non-Stemi at one side and Stemi at one side, and that just makes me like figure out super easily. So I have this over here. I will give you a second and try to see which one do you think is under the category of Stemi and which one is under the category of non-Stemi and unstable. Take a minute. Okay, so this is a normal blood flow. This is what you want. All of a sudden, there could be the plaque buildup, which is still stable because of all those neutrophils, all those LDL, triglyceride coming together, making the new plaque. The blood flow is reduced, but there is still a blood flow. That's your unstable or non-Stemi, where you have occlusion, but it's not total occlusion. But then that once stable plaque got ruptured, and that rupture can cause us to have platelets come and try to save us, which in turn causes us to have more clot formation, causing us to have complete occlusion, which is your Stemi. So if you guessed it right, good job. Now, what are the different things that happens with the EKG? We said we have non-Stemi and unstable angina on one side. So with the non-Stemi, when we say the word non-Stemi, in simple word, what we're saying is we have non-ST elevated myocardial infarction, where we have the partial occlusion. Whereas in Stemi, we have the complete occlusion and we have ST segment elevation. We will have an EKG which we'll go over, but in simple term, when we say Stemi, this is a P wave, QRS, and T wave. So Stemi is ST segment elevated myocardial infarction. So this is a MI, means heart attack. Heart attack because of the elevation of ST. So this is your P, this is Q, R, S, and usually this is your T. That's the normal thing. This, let's say, change to P wave, QRS, and QRS, and the T is supposed to go like this, but in this case now is like this. So you have QRS, T. You see your ST over here is totally up, elevated. So that's why we call it ST elevated myocardial infarction. Whereas in non-STEMI, which is your NSTEMI, you have P wave, QRS complex, and T wave is either same or it is kind of inverted. So it is either not elevated or it is inverted. So that's why we have non-ST elevated myocardial infarction. So we are having a heart attack, but your ST segment is still not elevated. Okay. All right. Now we have ischemia, injury, and infarction. Ischemia. What is ischemia means? Reduced blood flow. Why? When we will have the reduced blood flow? When we have, so this was the artery. If there is slightly occluded, then you'll have ischemia, which just means the reduced blood flow. So with the reduced blood flow, there is occlusion, but there is still ability to go. So you will see that in unstable, and you will see that in non-STEMI. With injury, now it is completely occluded, and now there is an injury. Why there is injury? Because there is no blood flow. So you'll see that in STEMI. So injury will be in STEMI, ischemia will be in non-STEMI. Infarction means the dead tissue. Previously it was dead, and that's when you'll see this Q wave depression. So we'll talk about that, or we'll try to see if we can find some EKG, but that's what we have in the nutshell over there. Now let's talk about the evaluation. Let's not go in super detail, but with the blood test we will do the troponin, CKMB, but the most definitive one we have is a troponin. What happens that the troponin level begins to rise in the first 3 hours after the injury, and are more sensitive than CKMB, which is like specific for MI, for the cardiac muscle cells. So when we say CK, it's like for all the muscle cells, but when we say CKMB, then it becomes more for cardiac muscle cells. But again, troponin is what we do, so just remember the troponin is what we will check for. When the other thing is cardiac markers are present in STEMI and non-STEMI, but they're not present with the unstable angina. Okay. Then again, one more time, unstable angina, no ST elevation, similar with non-STEMI, but the only difference between NSTEMI and unstable is you'll see no cardiac marker in unstable, but there will be a cardiac marker in stable and STEMI. Okay. Treatment, monoizina, other mnemonics, morphine, oxygen, nitroglycerin, aspirin, but that was the old one. We have a new one now. So one more time, quick review. Unstable angina is associated with one stable atherosclerosis plaque. It's the stable one. Pain that is new in onset occurs with less physical exertion, lasts longer than the 20 minutes. So you'll have the pain that will not go away with rest. It is kind of like different than the stable one. So with stable, you have the pain from 3 to 5 minutes, which goes away with rest. With the unstable, you're not stable. So even with the rest, the pain is still there and will last for more than 20 minutes. That's what we have for the unstable angina. Okay. With unstable, you'll see the ST depression, and there is no cardiac marker, and I'll pay attention to that. For minimum to no elevation of the cardiac marker, that's one of the other things which we can use to differentiate between unstable versus the non-STEMI. For this, what do we want to do with both non-STEMI and unstable? Stent placement will be a really good idea. Non-STEMI and STEMI. Now, all of a sudden, that non-STEMI became to STEMI, where we have a sudden complete blockage in the majority of the coronary arteries branches. It is, can cause us to have ischemia, which can cause us to have the death. So we'll have ischemia, injury, and infarction. We already talked about this, so we're not going to waste too much time on that. I have MI healing process, which we can read through, but it's not something that's going to be tested heavily on. So within the first 24 hours, leukocytes infiltrate the area of the cell death, which increases the white blood cells. Enzymes are released from the dead cardiac myocardial cells, which is important for the indication of the MI. So the cardiac cells, whenever we have the cardiac cells, when it starts to die, that's when troponin is released. So the high troponin means high death of the cardiac cells. Proteolytic enzyme, or the neutrophils and the macrophages, remove all the dead cells on the day 2 and 3. That's the time when we have to get rid of those dead cells from there. Then we have the collaterals formation as well, where we have, let's say that this is a plaque, then there is a new pathway formed, which is a collateral. You will have the EKG changes. By the week 6 after the MI, scar tissue will be replaced with the necrotic tissue, and it is said to be healed. You will also see the ventricular remodeling due to the so what happens is, when we have the ventricle, if there is a problem, let's say that anywhere, then due to the injury to the ventricle, the cardiac muscle cells starts to beat harder and harder to meet the demand, which can cause us to have increase in size, which will decrease the contractility, which decreases the cardiac output. So that's when we have the ventricular remodeling, which is just the increase in the ventricle because it's not working effectively. It starts to pump harder, and with working harder, it increases in the size. Sign and symptom, first one, anginal pain. That's a hallmark of myocardial infarction or heart attack. The other things you can see is over here, sympathetic nervous system starts to release the catecholamines because the body starts to freak out. They're like, oh my god, what's going on? So during this initial phase, you'll be diaphoretic, vasoconstriction, tachycardia, and the the low blood pressure will override by the stress response. You will also have the manifestation of the low cardiac output by, so when we have the low cardiac, if the heart is not getting enough blood, it's not pumping. If it is not pumping, then it's the backing of fluid, the blood back into, from the left ventricle to the left atrium to the lungs. It can cause us to have the crackle, hepatic engorgement, and those kind of things. Treatment, we talked about the MONA drug. We have the cardiac cath, where we go through the left radial or right radial side all the way to the heart, put the stent where there is a occlusion. We can do the pernicious cardiac intervention, which is a stent placement, or cardiac cath, where we will just see, and where there is a occlusion, study that. Physical therapy is also an options with non-STEMI and STEMI prognosis. Short term, in hospital or 1 month, mortality is lower with non-STEMI, but there is a higher chance of having the heart attack again with non-STEMI. So long term, if you look, there's a higher chance with the non-STEMI, because yes, non-STEMI is not a big problem, it's an occlusion over here, but there is a chances that you'll have another heart attack or another heart attack, or even the fact that once it was non-STEMI can change this to become STEMI at any point. All it will need to take is the rupture of this once stable plaque. So with the non-STEMI, EKG changes, no ST elevation, and there will be T-wave inversion, and there will be elevation of the cardiac marker, which is just troponin, CKMB. MONA in the pre-hospital setting, but now we have the new treatment, which is your 5 A's. Anti-ischemic, nitroglycerin, dilates the vessel. Calcium channel blocker, do the same thing. Anticoagulant, make sure that there is no blood clot formation, new blood clot formation. Anti-adrenergic, beta blocker, because we don't want our heart to work really hard, so it will bind to the beta receptor and reduce the contractility of the heart. ACE inhibitor to decrease the blood pressure, lower the blood pressure, easier for the heart to work at that period of the time. And anti-hyperlipidemic, statin, we don't have a lot of cholesterol floating around in the blood. With the STEMI, there is a complete occlusion, there is a complete damage to the thickness of the heart muscles, there is a ST elevation, and the elevation of the cardiac enzymes such as CKMB and troponin. With the STEMI, you have MONA but P. So MONA P, which is your primary PCI, primary percutaneous coronary intervention, has to be done within, it says, 2 hours. You also have ABCDE, antiplatelets, ACE, beta blocker, cholesterol lowering drugs, diet, and exercise, those kind of things. With the new treatment, we have this thrombins 2 is the new MONA for us, where we have T for thionopyridine, which is antiplatelet drug, heparin, RAS, which is renin-angiotensin aldosterone syndrome blockage, or ACE inhibitor, or ARBs, oxygen, morphine, beta blockers, intervention, nitroglycerin statin. You don't need to go in any detail and remember every single drug, but just know like what's happening with different things. After the MI, after the heart attack, you can always have the complication of the dysrhythmias. At least 80% of the patient will have the MI. You can also have the PVCs, which is premature ventricular contraction, VTAC, and VFib. We need to know about the EKG, so I have made a small EKG. We'll go over that really quick, okay? Other includes pericarditis, which is the inflammation of the sac that surrounds the heart itself, pericardium, and it can cause us to have the cardiac compression, maybe even cause us to have the cardiac tamponade, which is just like the fluid buildup around the heart. So if the heart is beating like this and there is a fluid buildup around, it will not be able to relax properly. As a result, you'll have the different problems such as muffled heart sound, jugular venous distension, and those kind of things. You can also have the sudden cardiac death within 1 hour of the onset of the symptoms. 50% of the death from the cardiovascular health is account for that. But the one I want you to pay attention to is your Dressler syndrome. It's characterized by the pericarditis, so inflammation of the pericardium, the sac that surrounds the heart. But now there is an effusion and fever that develops 1 to 4 weeks after the heart attack. And these are the other risk factors. And now we have the EKGs, which you need to know. This is the normal sinus rhythm: P wave, QRS, T wave, P wave, QRS, T wave. Everything is nice. All of a sudden, your atrium is fine, but your ventricular starts to have the ventricular tachycardia. So your ventricle just starts to pump, 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 pump. It's not trying to fill. It's not. Atrium is not even doing anything. Atrium is like working at its own pace. So we have, this is the heart, the top part. First, we have the top part that's top part compressed, and then the bottom part compressed to inject the blood to the rest of the body. But in this case, the top part is slowly moving, but the bottom part is, with that, it's like quivering. Not quivering, but like it's randomly pumping with too hard and too fast. So it's kind of like semi-organized if it is organized. But the only thing is, one of the way to differentiate between ventricular tachycardia versus ventricular fibrillation, both of them, ventricular is beating really, really fast. But with the ventricular tachycardia, one thing is that it is fast, but it is organized. You'll see all the ventricles have its own shape. That's your VTAC. With VFib, they are more chaotic and these are more life-threatening. Both of them are life-threatening sign, and we need to use the defibrillator ASAP. But VTAC is a little bit more organized with its ventricular contraction, whereas defibrillation, they are more chaotic. You can also have something called the PVC, which is premature ventricular contraction. If you look at this image, you have P wave, QRS, T wave, P wave, QRS, T wave. Now it should be the turn of P wave. Instead of P wave, all of a sudden this ventricle comes out of nowhere and have its wave, and that's your PVC, premature ventricular contraction, where it will just contract randomly without even having its turn. So first atrium contracts, and the ventricle contracts. That's how it should go. Atrium contracts and ventricular contracts, but in this case, atrium contracts, ventricular contracts, atrium contracts, ventricular contracts, ventricular contracts again without waiting for the atrium. That's your PVC. With the STEMI versus non-STEMI, we already talked about this. You have P, QRS, and ST over here is elevate. This is the normal one. P wave, QRS, T wave, normal one. P wave, QRS, and T wave elevate. That's your ST elevation. With the non-STEMI, you'll have P wave, QRS, and T wave. Over here, this is the normal. This is slightly depressed. So either you can have the ST depression or you can have the T wave inversion. We have P wave, QRS, and T wave depressed. That's the EKG, and that's the basic thing you need to know about the acute coronary syndrome versus coronary artery disease in level 2 of Patho 2. If you need more information, let me know and I will go over that. But yeah, that's all we have. Thank you.